Hello, everybody, and welcome to this Diaceutics Lab Talk. My name is Justin Lehman, and I am the Network Growth Program Lead here at Diaceutics. Thank you for joining us today, where our lab leader panel will discuss their perspectives on navigating patient testing pitfalls, turning practice gaps into progress. Here is our agenda for today. I'll provide a brief introduction to Diaceutics and set the stage for our panelists. And together, Leah, Sean, and Kaylin will dive into a roundtable discussion. And then at the end, we'll allow some time for audience Q&A. Please be sure to submit your questions using the Q&A feature, and we will address as many as we can at the end of the presentation. So to begin, Diaceutics' mission is better testing, better treatment. And we are building towards a future where the testing ecosystem allows all patients to receive the right treatment at the right time. Our roots are in data consulting for the pharma sector for precision therapies, and we believe that leveraging data, smart technology, and lab participation can enable that mission. The focus of improving patient outcomes through information that is already out in the world is powered by DXRX. In our nearly 20-year journey building our tools and methodologies, we have learned it's not the technology itself, rather the interfacing of the benefits of that technology with industry, community, and scientific ecosystems led by individuals and you for patients. On both the left side of the screen and in the DXRX booth in the exhibit hall, you can find a link where you can sign up to join the DXRX network. It's free to be a member, and DXRX acts as our central hub for information on paid collaboration opportunities, lab talks such as this one, and other insights to our data via dashboards and various news articles. We hope to see you over on DXRX soon to join us on this journey. In fact, we just launched a paid survey opportunity and are actively recruiting U.S. lab leaders to participate to share their experiences from within the lab. Spaces are limited, so check the link under the banner message to register your interest. If you are not eligible or you miss out on this survey, we do intend to have more options available in the future, so stay tuned via DXRX. Now, it is my privilege to introduce each of our fantastic lab leaders today. First, Kaylin Engel, whose title currently reads Lead Histotechnologist at UC Health, but was recently promoted as of this week to Supervisor of the Histology Department. Kaylin, thanks for being here with us today. We're happy to have you.
Thank you. I'm happy to be here as well.
Next, we have Sean Tucker, who is the Executive Director of Academic Campus Laboratories at Barnes Jewish Hospital and St. Louis Children's Hospital. Sean has been in the lab for quite some time and is currently on the chair of the ASCP Council of Laboratory Management and Administration. Sean, thanks for being here as well.
Yeah, thanks for the opportunity.
And finally, last but not least, we have Leah Mizisin, who's a seasoned healthcare leader with over 2 decades of experience in anatomic pathology operations, and she's the Director of Pathology Services at Scripps Health in Southern California.
Hi, thanks for having me, and good morning from San Diego.
Fantastic. So let's jump into today's main event. We're here to explore a critical topic in the field of precision medicine, and that is the practice gaps which are limiting the full potential of the promise of precision medicine. Our discussion today will be grounded in the findings of Diaceutics' publication called The Impact of Clinical Practice Gaps on the Implementation of Personalized Medicine in Advanced Non-Small Cell Lung Cancer, which was published in the Journal of Clinical Oncology. This research, developed in collaboration with the Personalized Medicine Coalition, identified 7 key clinical practice gaps which are preventing patients from receiving the most effective, personalized treatments that are available on the market. While this publication addresses those with advanced non-small cell lung cancer, it's evident that these gaps could exist throughout other disease states as well. The data that you see here was normalized to 1,000 patients, so the impact of each gap could be assessed with greater clarity. You'll notice different gaps result in a different amount of patient fallout. So on a patient's testing journey or treatment journey, which goes from left to right on this visual, 644 patients out of every 1,000 will fall through the various gaps. Despite the rapid advancement of diagnostic test improvements and targeted therapies, the reality is sobering. Up to 64% of patients may not receive the optimal treatment for their condition due to breakdowns across the diagnostic and treatment continuum. These gaps span from inadequate biospecimen collection and delayed test turnaround times to more systemic issues like reimbursement challenges and fragmented care pathways. In response, Diaceutics convened a multi-stakeholder forum to not only highlight these issues, but also propose economic, policy, and operational solutions to close these gaps and ensure that precision medicine reaches every patient who is eligible for it. You can check out the economic forum on DXRX as well. So today we'll be diving into some of the most significant practice gaps with our expert lab leader panel. We'll explore the real-world challenges laboratories face, the innovations they're implementing, and the collaborative efforts needed to drive change across the healthcare ecosystem, with an emphasis, of course, on the lab's role in alleviating each of these gaps. We encourage you to check out the link to the side under the resources to download the full publication, and you can read that at your convenience. So enough from me. Let's get into some questions with our panel. So the stage is set, and we'll begin with practice gap number 2, biospecimen collection. So this is a gap that is influenced by the specimen collectors. However, starting our discussion here is important as we consider the collaboration between the lab and other departments. Patient fallout of the precision medicine treatment pathway here due to insufficient tissue collected from biopsy, likely resulting in a rebiopsy. Of course, the specimens are not collected by you guys in the lab. However, can you share your methods of giving feedback to other departments to make them aware of the impact of collection challenges that exist? And Leah, maybe we'll start with you on this one.
Sure. Thanks. I think our biggest method is really heavily reliant on the pathologists. So the pathologists are talking to the clinicians. Obviously, if we're unable to send their tissue sample or tissue block out for additional testing because it's QNS or the tissue's since been exhausted, that's one level of education. But we also do regular in-services with the different departments around Scripps Health. So my supervisor and I, we will go to, say, the GI suite to talk to them if we're getting mixed up samples or mislabeled samples or whatever the issue is. And then we have twice a year, we meet with each OR group and talk about the importance of formalin fixation for all samples, but specifically breast biopsies. We'll talk to them about the importance of getting it to the lab quickly, anything about cold ischemic time or fixation time, doing a warm handoff. We require warm handoff at Scripps where that nurse or OR technician is physically handing the specimen directly to one of our pathology staff. We review everything that's supposed to be there, how many bottles, making sure everything's labeled correctly before we even turn around and start processing anything in the lab, just in some attempt to give feedback immediately or ask for corrections immediately. But lots of regular education from pathology to the other departments.
I can certainly add, we have implemented barcode scanning of tissue specimens for tracking of transport to help alleviate some of the connection or the transportation issues that we have seen with potentially lost specimens. I do believe that this is probably the primary area where RFID tags could be implemented within a system for laboratory tracking and specimen tracking in particular to help making sure that these unretrievable specimens do not get lost, and being able to utilize that. I would also say that we have done some pretty intensive education and work between microbiology and histology as well on fresh tissues. Fresh tissues are very time sensitive and a critical component. And so assuring that everyone is well educated on that process to make sure that it's expedient and that we are monitoring turnaround time to assure that the tissue degradation is minimized. So.
Yeah, we have a similar process as Leah. Our pathologists are mainly the ones who give that feedback. As a lab, we don't give that kind of feedback. In other aspects, we have like a patient safety. If there's anything wrong with patient safety, like mislabeled containers or the paperwork and the specimen container don't match up, we have a program called RL Solutions where we can log in all that information and it goes directly back to the originating department to give them that feedback, and we can work on those issues together with them. However, we don't do that with like insufficient tissue, like we don't log it in that system. So that would be an area that would be great for us to start logging those concerns there as well.
Fantastic. Thank you all. Let's move on to gap 4. We won't hit all of the gaps today, but we're going to hit the ones that have the largest patient fallout and how the lab can help support with those. So moving on to gap 4. So many in the patient treatment pathway might say that the oncologist is solely responsible for ordering all of the correct tests for their patients. This is the third largest percent fallout area for patients who may have been eligible for precision treatment. As lab leaders, how do each of you contribute to creating access to diagnostic tests which should be ordered or selected for patients?
I can start. So the initial diagnosis comes from the pathologist. We give them an H&E, they look at it, and we have all of our in-house IHC that they can order from. So they're able to get the initial diagnostic on that specimen. And then from there, the report is given to the oncologist. And then from there, the oncologist is responsible for ordering the biomarkers, sending out for genetic tests, and they're educated in that. So they put in the order with us, and then we can send out to reference labs. We don't do any of that testing in-house, so we send that out. But the pathologist and the oncologist, work closely together, and they're aware of what we can do in-house versus what we get to send out, and like the time that takes.
Sure. Leah or Sean, do you have anything to add on that?
Yeah, certainly. So we also incorporate our genetic counselors into this as well. There's a number of things that have to be considered in order for patient testing to be approved. And some of that is contacting certainly the oncologist for appropriate testing and test utilization, but also the insurance company to make sure that the patient isn't stuck with a very large bill as well. And so our genetic counselors are certainly trained in understanding what the appropriate testing is for that and work closely with the oncologist there. We also have a department of genetic scientists that are adapting these new technologies, this new molecular testing as well, who are working with our oncologists as well. Many of these reference laboratories might meet with the oncologist directly and forget to contact the laboratory. So we want to make sure that there is a connection oftentimes between the pathologists and oncologists about reviewing new referral or molecular testing platforms that are available on the market, especially for referral testing, to make sure that it's the most appropriate test for their patient. We have several levels of committee groups that will review that technology and the efficacy of that, as well as the cost and reimbursement practices as well. Again, we don't want our patients to be met with unnecessary bills if not appropriate. And so that we take all of that into consideration before we build that test orderable within our HIM system. And so the oncologist can then order it, and we'll see the results later on after that is built. So kind of several points of collaboration, much like Leah had mentioned earlier, regarding that communication between pathology and our oncology team, specifically in this circumstance, where we're making sure that it is the most appropriate test for those patient populations. And then that allows us to connect with other research grants that are available. Oftentimes the laboratory gets involved with blood collections for this research. And that is certainly a unique connection or collaboration that we have to have with those research clinicians who are leading those projects to make sure that everything is billed appropriately under that research project itself. And so just communication pathways are incredibly important in establishing that the molecular testing is the correct testing for the patient.
I don't have much to add. I'll just echo what they have both said, Sean and Kaylin. It's for us primarily pathologists and the intra-department communication, mostly at tumor boards, making sure we're up to date on best practices, standards of care, and recommendations between the providers.
Absolutely, and you kind of hit on kind of a sub question on that, Leah, was about tumor boards. When you're at your tumor board, do you discuss any type of reflex testing? Does that happen automatically, or is it more of a manual process for a pathologist to reflex a certain test?
Ours are pretty much automatic. Anything that's known as a standard reflex test, that happens automatically. I do think that there's some that aren't maybe built into the system as automatic, but the pathologists and our oncologists or other providers kind of have a standard understanding of, hey, I know, for example, one of our breast surgeons, pretty much no matter what, she wants that ERPR HER2 done FISH and IHC. So just kind of knowing preferences as well. As Sean said, we don't want to clobber the patients with unnecessary testing, but also making sure our providers are comfortable with our lab results as well.
Absolutely. Yeah, the test stewardship, I think, is the term that comes to mind, when we're trying to think about which ones will benefit, but which ones are maybe a waste or too expensive and unnecessary, depending on each patient's specific presentation. Okay. Let's move over to gap 5. And anytime Kaylin, Leah, or Sean, if you want to, reference a previous gap, please feel free to jump back if we need to. But for now, we'll go into some really laboratory-owned practice gaps. So gap 5 discusses how patients might miss out on precision medicine due to test performance issues such as false negatives or inconclusive results, or even technical failures, something that we really own within the laboratory. What are some ways that your teams are addressing testing performance to ensure fewer patients missed out on optimized treatment? And please go ahead.
Go ahead, Kaylin.
So at UC Health, we're a CAP accredited lab. So we're already held to those really high standards. So any new equipment we bring on board, we validate that. Our standing protocols are validated, lot to lot validations of our antibodies and detection kits, control tissues validated before putting into use. So by the time we get that patient tissue on the instrument to stain, we've minimized a lot of those risks of false negatives, inconclusive tests. Of course, there's always room for human error and equipment malfunction. So we have to deal with that. We have policies and procedures in place to how to handle that. That does give a slight, increase the turnaround time, depending how long we can repeat that slide. But we always hold our stains to the highest standard, to give the patients the best care they can receive.
Yeah, and just to add on to that, certainly barcode scanning as part of that workflow process whenever possible for patient identification reduces those errors over long term. But I think what laboratory leaders can certainly do is create a culture of safety. So you've probably heard of definition high reliability organizations, or HROs. that are using Lean and Six Sigma practices to help reduce errors and improve throughput, right? So whether that is huddling with your team at the beginning of the day to make sure that they have the supplies and equipment that they need in order to care for patients, or having some sort of a problem-solving opportunity where issues can be identified by frontline staff, and they have a culture where they feel safe speaking up and speaking out regarding issues within their workflows that could affect patient care and patient outcomes. And so it is up to us as leaders to create that environment where our employees feel safe to be able to speak up on concerns that they have regarding quality and safety. It's one of those requirements, like Kaylin said, under CAP accreditation, that they're able to be able to identify severe problems that could be potentially causing patient harm. And so I think it is certainly also the responsibility of the leaders, not just our frontline staff performing this testing, to create that environment, focus on safety, be reviewing our key performance indexes, or those KPI metrics that we're looking at for the department itself, reviewing that with our frontline team as well, to make sure that they are connected and engaged to the mission and what we're trying to do. And overall, that allows you to focus on safety, focus on quality, reduce the amount of errors, and certainly the amount of errors that reach the patient. Like Kaylin mentioned earlier, through safety event reporting mechanisms, that you are tracking those on a regular basis to identify issues, whether pre-analytical, analytical, post-analytical, and be able to address those through your process improvement. And again, sharing that information with your frontline team to allow them to participate in some of those decisions that will improve outcomes and improve patient safety as well. So developing a culture is pretty important.
I echo what you say there, Sean. I feel as though my role with our histology team in particular has been helping them focus on the patient care aspect of what they do every day, every specimen they touch. Don't worry about the finances and all that. Let me worry about that. A big area of concern that always seems to come up is, if you have a relatively scant sample and you've got, say, 20 sections on your water bath as a histotech, but the order only calls for 10 of them. I tell them, don't waste those sections, right? That's valuable tissue. Pick them up. I don't mind if it's an extra 10 slides that we're going to store or use on this case. That's nothing compared to, what that means for the patient and testing. I would hate to have to turn around and say, oh, that block's exhausted, when really we had extra sections on our water bath we could have saved. So yeah, just making sure with the staff they understand kind of the bigger picture and not to worry about the pennies and dollars. That's something for me to worry about, but to focus on the patient care aspect.
No, that's great. Please go ahead, Sean.
Yeah, one cool thing that we're looking into as well. So the CDC has created a virtual reality training simulation focused on safety in particular, but they're looking for players to help advance virtual reality training, and I could see competency assessment being part of that. As department leaders or someone who's worked in the laboratory long enough, there are some test systems that are just very difficult to observe competency assessment on all your staff, especially for large teams, if they're not often tested, right? So those low volumes. And so potentially integrating virtual reality into our ability to observe competency assessment or train and test individuals for their test performance is certainly an opportunity that I think we should be looking into in the future, not just for how to appropriately inoculate something under a biosafety cabinet, but potentially how to cut different types of tissue on a microtome. And so I think there's certainly some opportunities for us to build in more repetition and training competency assessment within our daily workflow that, certainly minimizes error and safety events, but also reduces the overall costs as well for training.
I would love that.
We're working on that. And here's
Sean, that's something that you and your team are already implementing or have implemented?
Yeah, that's correct. And so the CDC has a program where if you implement some of their safety training within any of your clinical laboratories, they will help supplement the virtual reality goggles. And so that we have been working with the CDC on that specifically. ASCP is also a partnering sponsor in that. That being said, our nursing department has been using virtual reality for bedside training in their virtual classrooms. And so we are trying to integrate with their software provider to see if there's opportunities to add some of our actual, physical repetition training competencies within a virtual environment for laboratory training as well.
That's really cool. Sean or Leah and Kaylin, did you know that existed?
No, I did not.
Very cool.
Oh.
That's such a cool thing to learn, right? And I hope the audience can hear a snippet like that and kind of take that away and maybe even implement it in their own lab. So this is what we do at Diaceutics, is try to have labs support labs. So thanks for sharing that, Sean. That's fantastic. Very good. Let's go ahead and move on to gap number 6. This is another one that is really owned by the laboratory team, and that it's turnaround time. While this gap results in fewer patients lost, it's one that can be directly addressed by lab leaders and by lab staff. Can you share a specific initiative you've seen your labs implement to contribute to faster turnaround times?
I can speak to that. So as specimens come in, we kind of categorize them based on priority and specimen. So we color code the cassettes. So those high priority cases like stat, like the needle cores, lung cores, livers, breast biopsies, those all get put into fuchsia cassettes. And that's our indicator that when the embedders come in the morning, those are the first things they embed. When the cutters come in, those are the first things they cut, because those are the type of specimens that are more likely to get IHC ordered or required for additional tests. So the sooner we get that on the pathologist's desk, the sooner they can order that, the sooner we can get those staining, and then the patient can get a diagnosis. As well, those fuchsia cassettes will usually pick up unstained slides, kind of like Leah said before, those tiny biopsies. We want to conserve as much tissue as possible. So we'll pick up unstained, and then preserve as much tissue in the block. If they need, that block needs to be sent out for reference to reference labs for biomarker testing. And then we have those slides available. If they order IHC, we put a control tissue on that, and then it's ready to go. So that turnaround time with IHC is really quick. We've gotten it down to like a good program. Like we're a well-oiled machine. We have our process in place that works for us.
I will second again what Kaylin said. Very histo heavy in our efforts as well. Now, regardless if a clinician orders a sample as a stat, if it's something we think needs to be handled as a priority for the pathologist, we'll go ahead and make it a rush or stat. Same thing with our cassettes, and our order sets even have unstained in them, a lot of our order sets, because we know they're likely to get sent out. We also sometimes will do where if we have multiple core biopsies, we'll separate them into 2 cassettes so that maybe while histo's doing a few extra stains for the pathologist, the other block can go ahead and be sent out. Anything we can do to get a little bit ahead. We actually just this week met with, I don't know if any of you are familiar, but IDELA is the name of the platform. So it's actually does some biomarker testing in the histology lab that can get you an answer in about 3 hours, it sounds like. So you still can send out for NGS panel in addition, but at least maybe the clinicians and the patient get that first line of treatment answer in a couple hours rather than a couple days. I know sometimes our send out tests take a while. So we're always thinking ahead, trying to think of what else we can bring in-house, not just for revenue for us, but to benefit the patient and the turnaround time. We're really excited. Yeah, all kinds of little tips and tricks we try and tweak to get these specimens through faster. I will say a big piece for us too has been digital pathology. Our pathologists are spread out across San Diego County, which is huge, all the way from the border up to 2 hours away. So minimizing the transport time of the glass slides, not everything, but where we're at in our DigPath journey, that's made a huge, huge jump for us too. So some of our pathologists actually start reviewing their cases at home first thing in the morning and get their same day stains ordered. And by the time they drive in after the morning commute rush, they have their same day stains already ready to go. So by that afternoon, we can have a case ready for send out. So digital pathology and, obviously any kind of technology advancements has really kind of jumped us forward in the last few years too.
Yeah, they certainly covered quite a few great ideas and opportunities that have been implemented in our labs as well. Cutoff times for tissue processing of fatty specimens to make sure that they get adequate time on the tissue processor is important. The different color-coded cassettes, like you mentioned, integrating barcodes to help with patient identification, speed that throughput up, as well as slide labelers, for example. Are all critical for that workflow. Now, I think, like Leah mentioned, the biggest opportunity for the anatomic pathology department is in digital pathology, and what we can do with digital pathology and integrating artificial intelligence to oversee the entire patient care and precision medicine operation. So we have been digital with frozen sections for quite some time, and so we're able to mobilize a digital platform that can be operated by a pathologist remotely, and so that the pathologist does not have to be present. It takes a grocer to be present in order to support that technology remotely, and so we've been able to do this at several of our satellite surgical centers to where you can centralize your pathology team and hire a grossing tech to help perform some of that surgical side technical skill set, and then using what we use a Grundium scanning technology allows us for us to be able to perform that testing remotely for our surgical procedures. Digital pathology is kind of that next level where you can be able to turn around your pathology reports much sooner, and then potentially with the automation of quality control, making sure that tissue adequacy as well as slide staining adequacy is appropriate. That's going to continue to develop, and then we'll certainly be able to integrate both radiology results as well as pathology results and molecular results together in order to use and build algorithms that help support patient care and lead to diagnostic times and treatment plans that are much quicker than we are currently doing in today's present world. That also allows us to interconnect with pharmaceutical companies that are doing research in real time as well. And so the sooner that your organization is able to implement digital pathology and come up to these platforms that are able to be interconnected with some of these research companies, the more advanced opportunities you're going to have for patients to be participants in research trials moving forward, your organization will be prepared for. And so that's certainly, I think, one of the greatest areas. In addition to, utilizing robotics when you can. And so I'm from the clinical pathology side, and so we've been using robotics for quite some time. I think this technology is coming to anatomic pathology as well. I think we've seen that through automated H&E stainers, as well as even there's microtome technology as well available for large processes or large laboratories to integrate some of those robotics as well to help with throughput. I think these are kind of the opportunities in the future, and certainly artificial intelligence will allow us to connect digitally between our pathology department, oncology, and radiology services.
All of those are.
Sorry, Justin. I had one other thought to add that's really benefited us is a local reference lab. It's a large reference lab. Lucky enough for us, it's very local, but we have an interface with them, and we have hard stops where if we forget to fill out some critical piece of information, it won't let us even submit the order, and they really can't pick it up from us at that time. So eliminating any of those kind of pre-analytical for that reference lab delay has also been a huge help, rather than us having to get a phone call the next morning. Why you're missing this info. Now there's really no delay in them getting started for us. So that interface has been key for us as well.
Absolutely. I think you make a good point there, Leah, that it's not, when we talk about turnaround time, everyone in this panel and probably everyone within the audience who works in a lab agrees it's not just about doing the test fast. There's so many different factors that go into completing a test, from slide prep and tissue cutting and grossing, some of the things that Sean and Kaylin mentioned. If we could spend a little bit of time on like even before the pre-analytic, right? Maybe overcome. I know in some of our previous discussions, we've talked about working closer with your courier team, educating the nurses on what they can do to help with some of these clerical items or specimen prep items to ensure that once it gets to the lab, it's that much smoother of a process. Each of you work at a multi-hospital system. So maybe if you could hit a little bit about some of the other teams that are involved and can help contribute to a quick turnaround time outside of the lab.
That was a big pain point for us for a while when we insourced our histology lab and kind of centralized all of our outpatient clinics into one space where all the specimens are sent. And we had staffed and designed the lab to receive specimens late, gross until 8:30 p.m. We were ready, but it seemed like everything was bottlenecking, showing up right at the end of the day. And at first I was kind of hounding our couriers. Why is this taking so long? We need faster routes, things like that. But it turned out it was even further upstream. So it was a lot of times the nurses in the clinics that didn't have time to package up those specimens right away, pair them with any kind of requisition, and then get it to the courier pickup spot. So they were kind of waiting to the end of the day to batch send them to the lab, which, coming from 44 different clinics and ASCs across San Diego, that was just killing us. So we did, like we talked about before, a lot more education. So I went and visited several of the clinics, talked to the nurses, like, hey, I know there's at least one of you going on break every 30 minutes. Can one of you walk it down to the courier? Whatever's ready, walk it down to the courier. As fortunately, as a lot of you know, histology is kind of a batch process. So if you got it to me today, I could make sure it was processed and the slides arrived by a pathologist tomorrow. Or if you delay too long, you're going to add an additional 24 hours to that turnaround time, unfortunately. So I think a little bit of education about how the process works and how to speed things up was such a simple thing, right? Just, hey, somebody get that specimen to the courier. Please, we're here, we're ready, we're waiting. Has definitely helped.
I can speak to a couple projects. One we're currently working on is improving turnaround of next-gen sequencing NGS tissue send-out testing. So again, interfacing with your referral laboratories, having an orderable built within your HIM system, but all of the other components, whether you still use paper or everything's electronic. Is there a referral laboratory portal that you have to go in? Does the oncologist have to go in there, or the laboratory? And who's responsible for getting those results in? And then certainly the interpretation on the back end as well, making sure that when those results do cross your interface or get faxed over, how are we getting those to the clinician in a timely manner as well? So we're currently working on improving that process because we have identified several delays that we're seeing in send out NGS testing on tissue blocks. And so making sure that we're identifying where those weak points are is critical. And we're using kind of, a process improvement platform where you do a root cause and to find out where all the weak points are, and then try to work through that process that way. But something we've had some success with recently is really on our bone marrow side. So our cancer center is located across campus. It takes 2 couriers to get the bone marrow specimen from that cancer center to our testing laboratory in our flow cytometry department. And it gets processed within our histology department, but then send up to a different floor for flow cytometry testing. And so we had to map out that entire pathway from the clinic where the bone marrow procedure is being performed, all the way through that satellite laboratory in the cancer center, through 2 courier systems that goes through another outpatient laboratory location until it gets to the pathology department, our histo department, where it's accessioned and then separated, and then the appropriate specimen is sent up into our laboratory for flow testing. And so just being able to kind of walk through that process, identifying where the issues are, speaking with frontline staff that are involved. But we also found out that we had to work with our nurses, our schedulers, and our physicians as well on making sure that we are appropriately scheduling these patients out so that it can meet these turnaround time demands and assure that flow cytometry testing can take place same day. Otherwise, we're identifying issues where we're delaying testing to the next day because some of these gaps and shortfalls. So we only have control over a certain amount of things, like Leah mentioned, the courier services, for example, or our routes through laboratory, how we get accessioned, who's accessioning to speed up that process, and what are we utilizing in order to speed up the pre-analytical process as well. And so one thing we have done is completed the validation of a pre-analytical robotic system that helps mix in the different cell types for flow cytometry testing, which was a manual pipetting process before. And now we're able to speed that up and handle multiple patients at one time. Because essentially we're trying to grow our cancer program, right? And our flow cytometry department needs to be able to match that load. And so certainly looking at the pre-analytical process, mapping that out with clinicians, with nurses, with our courier teams in our laboratory to break down bottlenecks and help improve throughput. But then also, again, kind of going back to opportunities to utilize technology and robotic automation to handle the volume that's needed as we continue to expand to grow, and when staffing becomes more and more challenging to hire for. I would imagine laboratories in California are similar to they are in St. Louis or in Colorado, that it is challenging to find trained professionals to come in and do this work. And so we're having to handle higher volumes with fewer people. And that's a bottleneck in itself. And so, yeah, I think that's all I have to say.
Thanks, Sean.
Yeah, touching on what Leah said about the couriers, it's an education thing for us too. We have 2 locations in Colorado Springs that gross the tissue, a central and a north. And at the end of the day, all the north specimens or the cassettes get sent back down to process at the central location. So when we have our usual couriers, things are running smoothly, but they go on vacation. So when we have those people filling in, we have the PAs waiting here at the end of the day, waiting for these cassettes to come so that they can load the processors on time and leave. So it's just, education, like these times are crucial, to get this here on time. We can get the processor started to get, them out on time.
Very good. Thanks, Kaylin. I want to transition and get stuck into the gap with the largest patient fallout, which is gap number 7, treatment decision. So even when a patient runs smoothly through the first 6 gaps, the tests are ordered correctly, the nurses get the specimen to the right bucket for the courier to pick up, the lab runs the test efficiently and on time, and the patient receives a positive result, we still see that patients are administered a non-precision therapy. Can each of you speak about the ways that your test results are relayed to the ordering physician on your reports? So now we're getting into the report content a little bit. Of course, it's up to the patient's care physician to ultimately prescribe the medication. However, how do you think labs can play their part to alleviate any results confusion? And how do each of your institutions assume report content responsibility to facilitate a more positive outcome and a more optimal treatment selection?
So in our final reports, oh, sorry.
Sorry, Kaylin.
Go
ahead.
In our final, do you want me to go? In our final reports, we don't give the treatment plans because that's left up to the oncologist. But we do lay it out, in a very easy manner. The diagnoses are very clear. In the synoptic reporting, the tumor stages, the metastasis, the lymph nodes are all laid out for the oncologist to make that appropriate decision. We don't make that decision for them, but we give them the resources, to do that for their patient.
We just recently had some issues with interfacing of complicated results. A lot of the molecular results are several pages long, and we had an interface that was trying to, I think, kind of simplify all of those pages into a blurb, and it was confusing and worrying everyone that we were missing something. So we recently just changed that to now say see attached PDF. They have to look at the attached full report. We didn't want to overly simplify it. We were worried we were missing something. So fortunately, I don't know if we're making it easier, but everybody felt a little bit safer about, making sure that clinicians are directed to seeing that full report instead of relying on any kind of abbreviated version.
Yeah, and I'll just add that unfortunately, hospitals, at least those that I've worked at, are still utilizing fax systems. Not every referral laboratory is interfaced, and certainly not every physician clinic is interfaced as well. And so oftentimes we have to resort back to faxed images and faxed reports that then need to be integrated into the patient's medical record. And I can't stress highly enough how critical this component is. When you are taking fax documents on multiple patients and assuring that they get into the correct patient report, it's just as critical as putting out the right result in the first place as a scientist, scanning in the correct report into the patient's medical record. Because unfortunately, you're going to see an event where the incorrect patient gets scanned into the report, or maybe in the middle of a report or a part of an addendum, and it gets misdiagnosed. And then the patient then gets on a treatment plan because of mixed results within the wrong patient's medical record. And so these are huge issues that healthcare providers as well as hospital systems are having to deal with because we haven't been able to solve this problem where we can communicate with each other efficiently and effectively. Even when you are interfaced, those interfaces can go down. They're very costly as well to begin or to set up in the first place. And you have to have the right resources available to help set them up and maintain them as well. And so unfortunately, we're stuck with fax systems for now, especially for some pathology reports. And I'll just emphasize how critical it is for the quality of that work in order to make sure that that information gets to the clinician at an appropriate time. Now, I would say that we've also utilized automatic report tracking. So if a report then goes in for a particular test type, that we can generate a notification system either to the oncologist or the clinician. Sometimes in our outpatient setting, this also might go to an ED workflow as well, where our ED clinicians are following up with patients who might not be seeing an oncologist yet, for example. And so that we make sure that these results, although it's not a critical value, these important results are being notified to the appropriate clinician in a timely fashion in order for them to either improve their communication timeline with the patient or help develop a treatment plan that's effective. And this is especially true and critical, I think, for our patients in underserved areas where they don't always have a primary care physician to follow up on. They might not have resources for specialty services as well. And so we need to make sure that we are not losing these folks through these gaps that have been identified in this report and this presentation today. And so just having clear communication pathways so that when those reports do get in, we actually hold them for a period of time before they're reflected on the patient's My Chart or whatever they call their personal viewer for the HIM. And so to make sure that we have time to notify the physicians that are appropriate to have that conversation, because this is so complex, the information is so complex. Half of our physicians don't quite understand it, not alone the patients who are seeing that for the first time on their phones at home. So.
Thank you all. At this time, I want to transition into the Q&A section. Now, I know we've hit on most of these gaps. We didn't touch everyone, and it could certainly be argued that we're only scratching the surface, on each of the complexities of each of these gaps. All of them are multifaceted and require a lot of different teams, to help support a patient getting from diagnosed to on a correct treatment. So we hope that some of the things that our panel provided sparks some thinking at your own institutions. And now we'll dive into some questions. And if you haven't submit a question, we encourage you to do so, and we'll try to address it. I'll start with one. This would not be a webinar to improve healthcare without a question about artificial intelligence, right? I think it's even popped up already. So how do you foresee the increased use of AI in the healthcare setting support filling in some of these gaps that you each spoke on today?
I think Sean already touched on it a little bit, but it's definitely with digital pathology and AI is going to change the way we do business. I think about, I don't know about everywhere else, but we are lucky and blessed enough that we really work daytime hours in pathology. Histology works overnight here, but I can only imagine, slides being read overnight now, Saturday and Sunday. Basically, as fast as histology can produce a slide, we can have it screened, at least pre-screened by some kind of an AI software, which would jump this whole pathway ahead by hours, even days sometimes. So I definitely think digital pathology and the AI software that is just coming out faster than I can even keep track is the future for us.
Yeah, I'd agree. Those who I've spoken with could certainly see artificial intelligence doing first reads on H&E and reflexing to additional stains. And so that by the time it hits the pathologist for read, that all of these appropriate slides, or at least the first path of appropriate slides are prepared for them to increase time to diagnosis or time to path report. And I think that will probably continue. Again, they already have solutions to improve quality control of tissue and stain, and we'll probably see cytology move in this area here very soon once it gets FDA approved. I started telling our folks start recruiting pathologists that live in Hawaii or maybe even Guam, right? So that we can continue our slide reads later into the evening or even the next morning. And so I think digital pathology is a huge game changer, as well as the introduction of artificial intelligence. And I think AI is going to just help support our challenges with staffing as well. How robotics and automation has helped support that is, I think artificial intelligence is going to allow us to see more of the patient picture when we are getting ready to validate or verify a patient result, and allow us to do so with more confidence. And so this can be through pre-analytical screening using AI algorithms to assure that something hasn't been contaminated, or that it's the appropriate tissue type, for example, or on the back end as well when we're getting ready to verify a result, and putting more of that clinical picture together, looking more historically into the patient's background and report to give our scientists a better representation of the work they're getting ready to verify and put into the patient's medical record. That then goes off to the pathologist or oncologist, or whichever clinician's caring for that patient. So we're going to see it. The workforce shortage is going to bring these technologies to the forefront, and so I certainly see them, being completely integrated within the next 5 to 10 years.
Sure, thank you. Sean, one of the things that you mentioned that I wanted to circle back to was about KPIs. So what types of metrics or KPIs, key performance indicators, are you using to measure the success of the changes that you make to help alleviate some of the gaps here? Do you have any examples of KPIs that you can share with the audience?
Yeah, I mean, we already touched base on turnaround times for both internal performed tests as well as referral lab testing, and this turnaround time to diagnostics are certainly one of them. Specimen quality is also one of them, right? So either QNS or on the clinical side, there's contamination and other issues that can delay patient care, and so we're measuring specimen quality as well, and then certainly our competency assessment and our ability to perform appropriate proficiency testing in our laboratories are also measures of our quality performance. And so we're keeping an eye on those as well.
Fantastic. Do you, Leah or Kaylin, have any other KPIs that Sean didn't mention that you routinely check in on?
He covered most of it.
Okay. Leah?
We check in on two others that I can think of, one being kind of a similar system that Kaylin referenced about keeping track of errors. We keep track of specimen rejection quite a bit and see if there's any trends. For a long time, not to throw them under the bus, but we were struggling with our dermatology groups. Lots of mislabeled specimens, lots of, what's written on the lid doesn't match what's on the label and things like that. So helping us kind of direct our focus on who to follow up on. So that's a big one. And then the second one is we have basically QA and histology. So lots of comments in our LIS system from pathologists every month. As they come up, we address them, but every month we run a report and then follow up. Is there anything we didn't address? Is there something we want to work further on? We're a little bit newer in the Epic Beaker world, but I keep encouraging our staff to let the computer do it, right? Let the software help us. We have this cool technology. Is there some report we want designed? Is there some functionality we can ask about? Really encouraging, the staff to have Beaker help us monitor additional issues, and even if there's a way to help follow up.
Most definitely. Something I feel like I've learned from the three of you is that communication, not just within the lab, but within all of the different people who are part of a patient's treatment pathway is key. The lab remains central to initiating all of those conversations that need to be had, whether it's about specimen collection or result reporting or things we talked about with the turnaround time. So it's my last question that I want to end with is, how do you juggle, right, the implementation of these really neat tools such as AI or technology in Epic Beaker to alleviate some of the issues, as well as the human aspect of communicating with other departments who directly play a part in your operations?
I don't know. I feel like we were speaking a little bit earlier about the importance of in-person and live communication. So I still think that's really important. Obviously, you can build a relationship on top of whatever issue you're talking about when you talk to someone directly or visit the department directly. We do rely heavily on Epic for communication and the pathologists for communication to clinicians. But I do feel like regularly rounding with our team, making sure they're comfortable with any kind of new technology or workflow rollout. I'm really big on big picture, making sure they kind of understand the whys and how anything upstream maybe impacts them. And something we regularly talk about is that kind of surprise element of our job description, that it is regular education. We are regularly talking to people about how you submit it, why this is wrong, what's the correct way. Well, it's daily for us. So I think just keeping it light with the team, not letting them get frustrated about some of those, daily pieces of being a laboratorian. It's part of it. it's not something to get frustrated with.
Thanks, Leah. Kaylin, Sean, any final thoughts on that?
No, Leah covered it.
Yeah, I mean, I think of it the same how I do artificial intelligence in my personal life. I want to make things more efficient so I have more time to spend with family and friends. I feel the same way in healthcare. We need to utilize it so that we have more time for communication, whether that be in person or through education, our connections across departments as well. And so making sure that we have the human component that artificial intelligence can't replace. That we are sure within our day-to-day operations, whether it's across teams or implementing new processes across different departments or different hospital systems. And so I wanted to give us more free time at work so that we can continue to be humans and improve those relationships, build business from that, and improve overall patient outcomes.
Fantastic. Thanks, Sean. I want to thank our audience for joining us today, whether you're here live or if you've listened to this recording. And one final thank you to our panel members for offering their time and their expertise. We appreciate you being here, guys, and I know patients appreciate the work you're doing behind the scenes in the lab and continuing to adapt and evolve to make this pathway better for them. We're honored to have you each here. We hope this session sparks some discussion within your own lab and empowers you to be an advocate of precision medicine for the patients that your labs serve. And we encourage you to reference the Practice Gaps publication, which is linked on the side panel here, and hope to see you on DXRX, where you can remain up to date on our offerings and various projects which are aimed to support the work of laboratories. Together, we can facilitate better testing and unlock better treatment for patients. Thanks, everyone. Bye.